Thank you. Good evening, and thanks again, once again for being so generous with your time and spending the evening with us. I know it's been a long day for everyone. So my talk this evening is going to focus on the 2017 HHP quality program around QPP and SSP, specifically around measures development and basically all of the thoughts and consideration that go into creating a quality program for an ACO. So just an overview of our discussion tonight. So I want to just talk briefly about one playbook. So how we align we've made attempts to align our program this year with a lot of the other payment and transformation programs that are coming down the pipe that are going to impact all of our, everyone across our system. So with HHP, the 2017 proposed measures, we'll go over those briefly and just talk briefly about QPP and SSP. Much of that has been already covered in the various presentations tonight. So we'll focus mainly on what the new measures are, hopefully go through what's been modified and those measures that have been retired. We'll also talk briefly about what we learned over the past year and our timeline for finalization of our program and avenues for feedback moving forward. So what goes into creating a quality program? So the first thing we want to do is make sure that we are doing the work of an ACO. So we're not seeking to duplicate the work of others or payers or systems. We need to ensure that that as an ACO, our work is aligned with clinical integration efforts and population health management. That really is the role of an ACO. Keeping that in mind, when we start talking about a system of care between payers and providers and hospitals and health systems, we have two funding mechanisms for our programs, or our Hospital Quality Performance Program and our HMSA Shared Savings Program. The Hospital Quality Performance Program is intended to support the quality work that is currently being conducted within our hospitals. Our HMSA Shared Savings Program is work that is meant to support the work that's being done across our clinical work groups and various other initiatives across our organization that help support seamless care, timely care, efficient care, appropriate care, and that hopefully help us bend the medical cost curve. We also want to be aware of and align with our HPH system performance goals, and conversely, our work will typically also inform what those goals ultimately end up becoming. There are legal considerations and regulatory considerations that we have to ensure that we're always being mindful of, especially with regard to Stark and anti-kickback laws and our benchmarking practices. From a financial perspective, we always want to be mindful of point distribution and to ensure that where our points land in our system have enough reach and breadth, but also are focused in areas where our organization feels that we need to have a bigger effort. So in this case, much of it will typically land obviously in the hospital realms and in the primary care. We also have to be mindful of our payer partners. So HMSA's Payment Transformation Program is coming down the pipe. So we want to make sure that our providers are aligned with that our system is aligned with that, and that we're aware of the requirements that are going to be placed upon us by these new programs. This year, for 2017, through the HMSA Payment Transformation Program, we're looking at, so they have a new set of measures that they're implementing along with the individual PCP measures, and that is a set of measures for the provider organization now, so this is relatively new. We also want to be mindful of our federal friends over at CMS with the new macro ruling that's came out earlier this year with regard to MIPS and APMs and CPC Plus and MSSP. So there's a lot of three-letter acronyms to learn and are very overwhelming. But each of these programs has a set of requirements that come along with their measures. Some of them require cross-cutting measures to be present. Some of them require outcomes-based measures to be present. So we're trying to keep all of these things in mind as we move down the road with creating our measures program. Additionally, like I just mentioned, we want to be aware of the reach of our program. We want to reach as many providers as we possibly can. Our program should also be reflective of some level of accountability of our providers to deliver quality care. It should support our clinical work groups. We want to also make sure that we're promoting citizenship and engagement in venues such as this, where everyone can come together and listen and hopefully give some feedback. We want to make sure that the volume of measures does not continually grow, and that the measures that we implement aren't just another thing that you need to contend with, that they're lined up appropriately with the rest of the care that you're already providing. They should be applicable to both employed and independent physicians, be clinically meaningful and useful, and mindful of the specialty focus. So we want to be sure that we're including all of the specialties, especially our pediatric colleagues, in addition to our ambulatory specialists. So once we've gone through all of those thoughts and considerations and works and analysis, at the end of the day, we have a lot of great ideas for measures, but we have to be able to capture it, capture the data, right? So our data should be, everything we do should be data-driven, and it should be capturable. And that depends on our EHR, our vendor, what version we're running, and also whether or not we're in the midst of an upgrade, which should be upon us very shortly. We also need to be mindful of what is currently being reported by the system and the method by which they report. So you can report through claims, you can report through a registry, you can report through electronic interface, a web-based interface. So we need to be aware of what and how our system is actually reporting these measures that we are asking people to do. It doesn't make sense to do measures or to perform on measures that we can't report on or are currently not reporting on. So briefly, we have generated a list. We've been working really hard with our measures subcommittee and meeting almost weekly to pull our program together. So we have a QPP program, and this is just a list of, and I'll briefly run through them, of the measures that are on their way for 2017. Marty briefly spoke about the work that she had done in CKD and the fact that we have some measures in our desire. And I was happy to see when they polled you that one of your one area of interest of yours is to make sure that the problem list is current and up to date. So our first two measures here, ambulatory management of chronic kidney disease and inpatient support of chronic kidney disease, are aimed at doing just that. So, and this is an effort to bridge outpatient kidney disease management with inpatient kidney disease management. So in the ambulatory setting, if you utilize the tools that Marty just showed you around heat maps, use of the heat map to help identify your patients who could potentially have chronic kidney disease, and if you, in your clinical judgment, feel that they, in fact, should have this diagnosis placed on their outpatient problem list, that then would inform the second measure, which is inpatient support of chronic kidney disease. So backing up again to the ambulatory management, if you take receipt of a list of patients drawn off of your panel and take a look at them and say, okay, you know, this patient may not need follow-up, this patient could in fact have chronic kidney disease or could be progressing, I'm gonna put this on their problem list, that will get you a point for that particular measure. If that CKD diagnosis lands on the problem list, then our colleagues in the inpatient management realm can see that it is present on the outpatient problem list, be mindful of it, move it over to their inpatient problem list, and hopefully that will help guide their any further inpatient management of their patients. That will help our hospital-based colleagues also earn a point. The severe sepsis and septic shock, we've been doing pretty well with that across the system. So we've decided to take the two measures from the previous years with the lactic acid measures and bring them into one large measure and follow the CMS SEP1 measure bundle, management bundle. So those two measures have been collapsed into one and been matured into the full measure set. Pre and post-surgery glucose will be carried forward. Exclusively breastfed newborns will be carried forward as well. Elective deliveries carried forward as well. Vermont-Oxford Network will continue to be carried forward, but they will be losing, I think, 3 measures from that category only because of changes in the way care is delivered. So the measures are not necessarily relevant to the work they do there anymore. So, so that is decreased from 8 measures baked into that one larger measure down to 5. Honoring pulse will remain. Advanced care planning will continue. However, some of the changes that we see coming down the pipe with CMS especially, they've dropped the age from 75 down to 65, so that's a modification that's being made to this measure this year. Our experience this year has also taught us that we need to decrease our reliance on measures that require extensive chart review. So for the upcoming year, we're going to ask that to gain credit for the advanced care planning measure, that that actually be coded for, and that's what we'll be looking for as we look to measuring performance. We also have a citizenship measure domain. So we are also, we're going to continue HHP work groups, as Marty mentioned, and that's open to all providers across the system in both the inpatient or the hospital and outpatient realms. So moving on to the SSP program, we've had a falls measure this in 2016, which we are going to carry forward, but in a modified way. We're making a big effort to align our measures with the CMS measures. And so we are going to be following the CMS measure 139 for falls risk assessment. We will continue our avoidable ED utilization measure as before. Controlling high blood pressure is one of those measures that is coming up in a very large way across all these, the HMSA front and the CMS front. So we're going to continue to carry that forward, but we're going to modify it in the sense that we're going to be following the CMS measure very strictly as well. Diabetes, A1C poor control is another one of those measures that is popping up everywhere. So we're going to, and then this one is new, but we're going to be following the CMS measure 122. Diabetes eye exam, it was present over the past few years, but we are going to modify it again in the sense that we're going to be following the CMS guidelines. Screening for depression will continue, and we're also looking for increased engagement as well, so use of the HHP dashboard that Jared discussed during his presentation for population health management is a new addition to our measure set. And of course, attendance and participation at the HHP annual membership meeting, like tonight, which is going to be continued. We have HHP learning modules that were very well received this past year, so we're going to continue that as well. The goal for the learning modules is to cover areas that will hopefully help you to manage the change within your practice, and while earning CME credit as well as SSP credit. One of the other important areas that we are trying to focus on as well is for our meaningful use participation and enrollment in My Health Advantage. So we're asking everybody to hopefully try and get as many patients as you can enrolled in My Health Advantage over the coming year. Citizenship. We've also been working on lifting and maintenance of certification committee. We've received American Board of Medical Specialties accreditation to hand out maintenance of certification credit. So, sorry, lots of three-letter acronyms again. So, so as we get our committee up and started, we're going to get some projects in and through, just so that we make sure that the committee's up and running. Into the following year in 2017, if you've already been involved in quality work that can meet the ABMS MLC guidelines of expectations, and also HHP quality improvement guidelines, then you are free to submit your work for approval by our MLC committee to receive MLC credit for the work that you're doing. This one is a lot of work, so this is a measure that's more heavily weighted, but in addition to doing all of that, you will also get, this one is slated to receive 2 points for our quality program. Also here, participation in HHP clinical work groups in the outpatient setting as well can also be funded through the SSP program. Some of the measures that were retired, we did pretty well with our stroke measures. So the stroke patients being prescribed antithrombotic treatment and with high LDL prescribed statin medication, those will be retired. Patient experience of care and for hospitals and emergency medicine will be retired. Transitions of care for hospitals and primary care will also be retired. Achievement and maintenance of PCMH level 3 is being retired, as PCMH level 3 is an expectation of practice moving forward with regard to many of the programs, HMSA and both HMSA and CMS, and some of our lingering screening measures and our CME. So So what we learned over the past year was that it is really, with the plethora of measures being placed upon all providers across all settings, that harmonization across all of these programs is of vital importance, so that we don't further overwhelm or burden our physicians. So we worked really hard to create one playbook this year, so that we lessen the confusion, but also reassure the providers that if they are following the HHP program, that it will help you in achieving your quality performance goals for all the other programs that you're involved in as well. We want to decrease, as I mentioned earlier, we want to decrease reliance on measures that require chart review. It's very labor intensive, and of course takes a lot of time and whatnot. It's a lot easier to generate cleaner, quicker data if we can just extract from our data repository. We want to simplify and align our resources. Our quality team at HPH has been just so incredibly helpful. We want to make sure that we're working as closely with them as we can, and on a regular basis moving forward, so that we can keep abreast of any of the changes that are coming and become a little bit more knowledgeable about the reporting practices and the little nuances of reporting. Improve communication, education, and support. We've heard from providers that they want to make sure that they're very, very happy to participate and want to participate. We have a very, very engaged group of providers, but they need more support and more education around these measures. So we're going to be making a concerted effort to get out more often in the coming year and do that. And we want to also focus on supporting physicians by supporting their clinical staff knowledge and understanding. So I think it would be, in terms of the short period of time that I've been able to in the recent months to be able to make my way through a few practices and have to talk to the physicians and their staff, it's become, I've been made aware that it's going to be very helpful to the physician if we can get in there and talk to the staff and help their staff understand, what changes are coming down the pipe and where they fit into all of this change. So, and also when we data report internally, to ensure that we have more quality assurance checks built into our process. So our timeline, we have a SurveyMonkey coming out for everyone to give feedback, where there'll be more detail on each measure. And we want to hopefully finalize our draft measures by the end of this month, perhaps moving into October. But we're seeking final committee approval, QCI committee approval, and finance committee approval, and board approval by the end of September. And we also have our annual meeting presentation on Kauai. Hopefully by the end of October, we'll have finalized our copy and print and ready for distribution by October 31st. November and December, we'll continue to train and circulate our measures program. So be on the lookout for this. It's coming. It is our SurveyMonkey that we sent out last year, and your feedback is very, very important and vital to our program. So we'll be sending that out soon. I look forward to your feedback. So that's it. Thank you. Okay.